Welcome to this Autism Ontario webcast, focused on finding our way through the healthcare maze, lessons from research on health services, with Dr. Yona Lunsky, PhD, Director of Healthcare Access and Research and Developmental Disabilities Program at CAMH. My name is Matthew Lay, and I will be your host for today's webcast. This presentation will explore what happens when individuals with ASD are in crisis and have to visit the emergency room. Today we'll be addressing what leads to an emergency room visit, how they can be prevented, and what we can do better to ensure that they don't happen next time. Before we get started, there are a few housekeeping items. We will be pausing from time to time throughout this broadcast to take your questions and your comments. You will note that below the video there's an Ask a Question box. Simply type in your questions or comments there and they'll be sent to me on my iPad, and I will ask them of Yona here on the desk. Now, we have a very large and diverse audience on the line today, and so we may not be able to get to all of your questions. Autism Ontario has committed to getting an FAQ out following this broadcast to ensure that most questions are answered, if not all of them. A couple other pointers, and when you're getting comfortable with the webcast console, one is that if you're having any issues with the broadcast, any troubles at all, you can go ahead and you can click the help button, and you'll be contacted with our support team. Also, beside us, there will be PowerPoint slides moving throughout the presentation, which will help inform our discussion. You can download those PowerPoint slides in the resource section, both in French and in English. And if you look at the resource section, you'll note there's a number of other links to content that we will be addressing today, and again, are things that support the discussion that we're having. So now that that's all out of the way, let's get down to why we are here today. It's my pleasure to welcome to the desk Dr. Yona Lunsky. Yona is the director of the H-Card program at CAMH. She received her PhD in clinical psychology from the Ohio State University, specializing in the area of dual diagnosis. She is an assistant professor at the University of Toronto Department of Psychiatry and has written over 100 research papers related to this topic, so we are certainly sitting with an expert today. Over the past 7 years, Dr. Lunsky has been studying the issues we will discuss today, working closely with hospitals, families, as well as policymakers, helping to develop solutions. And we're going to talk about some of those solutions in the broadcast. Yona, thank you so much for joining us.
Thanks for having me, Matt.
So what we like to do when we get started is try and create a baseline for our audience. I just said you've written over 100 research papers on this topic, been studying it for 7 years. What drew you to the topics that we're discussing today?
Well, a few years back, I was in a hospital somewhere in Northern Ontario giving a presentation on data we were looking at around hospital use, psychiatric hospitals actually, for people with developmental disabilities like autism. I presented all my data and I knew the story. And a brave father stood up in the audience and he said, well, after all is said and done, a lot more is said than done. What are you going to do about this?
Right.
You know? And it really made me think about what kinds of things we actually have to do to make changes in healthcare. And that the key place to focus on, probably where things sort of seem to explode sometimes when things aren't going right, is the emergency department. So we started a sort of program of research looking at what goes on in emergency departments from a variety of perspectives, like you say, talking to families, talking to individuals who were patients in emergency departments, talking to people in hospitals, and even working with policymakers to figure out what we can do to really change things.
Sounds like a very comprehensive study. Can you talk a little bit about where you're getting all of your data from?
Well, from different places. So one of the studies I'll talk about today uses data from somewhere called the Institute for Clinical Evaluative Sciences, where they take all of our health information from across the province and study healthcare patterns. Okay. So some of that comes from that sort of very big picture, provincial scope. Some of it comes from actually reviewing what happens in individual people's hospital charts. So we might get consent from a patient who'd been to the hospital to go in there and actually read what's recorded in the chart. And some of it comes from just following and discussing things with staff in the hospitals or with families. So one of the projects I'll talk about today involved following almost 400 families from Autism Ontario and from the province to look at what happens with their teen and their adult children over a period of about a year to see which health services and when they use emergency services in that time.
So pretty comprehensive. So what we do know when you're doing a study like this is that you're going to find some problems that do occur. And so just to get started, we're going to talk about a few things that maybe aren't working today. And to do so, you've been good enough to take some of the, I guess, through the interview process with people?
Through interviews with different people. We have quotes both from patients who've used the emergency healthcare system as well as from their families. So we just highlighted a few quotes here.
Sure. What I'm going to do is we're going to put them on the screen. I'm going to read them off, and I'm just going to look for you to provide some context. The first one, the lady on the screen right now is, this lady said to me, "You come in here all the time with this and that." She argued with me. I was upset about it, so I just left and went to another hospital.
Yeah, I mean, I think this quote really captures the frustration of the healthcare provider in the hospital with seeing a patient repeatedly, but also how difficult it was for that patient. So instead of actually really working to fix the problem to prevent her from coming back so many times, she kind of pushes her away, and in the end, our healthcare costs go up because she just walks in somewhere else that has no information on her to get the same service she was trying to get in the first place.
This next one, they don't understand that it is hard to be cooperative when I'm so agitated.
Yeah, I think, again, if you think about what it's like from the perspective of somebody on the spectrum, you know, if they're acting out, if they're doing things that look really bizarre, or maybe they're hurting people or they're hurting themselves, it's not that they want to do that, right? It's how much effort it takes for that person to do what they're supposed to in that moment.
Right. This one probably, you know, it's a very sad one, but maybe speaks to some of the parents out here. This is the third time my son has been to the emergency room with suicidal ideations. Each time he is sent home. Does he have to attempt suicide before anyone takes notice or action?
Yeah, I mean, it's a sad quote about, I guess, how in depth people in the healthcare system sometimes understand the problems that parents are reporting. So sometimes what might happen in this situation, you know, the family goes there because to them it's very, very serious. But by the time that young person is actually seen in the hospital, he doesn't look so bad.
Yeah.
And they say, well, are you going to do anything? Are you going to hurt yourself? No. Okay, well, it looks like, you know,
everything's good.
You know, try, you know, hopefully get some resources out there and, you know, try not to use the hospital. But, you know, there's much more going on there than I think the hospital system might be aware of. Okay. And that's really hard for families. I worry about families who have to go back to the hospital, but sometimes I worry even more when a family stops going to the hospital because of that interaction. Yeah. Right? Like, it's really important if something like that is happening to go back anyways, but make sure the people in the hospital get a good sense of really how serious the situation is.
Now, we've had many people on this desk talk, and we haven't really talked about suicidal ideations as it relates to ASD. Is this something that is common? Is this why it was highlighted?
I think it's something we don't talk about. Yeah. You're right. Yeah. And I don't want to frighten families and say this is something that happens all the time.
Something you should be aware of.
It happens in the general population, and if anything, the frequency with which this happens in people who are on the spectrum can be higher, particularly for those people who are aware of some of the differences between them and other people who have difficulties coping, who don't have the supports and resources in place to help them do so. Absolutely, that's what people do when they're feeling really depressed, right? So it's something that can for sure happen. Okay.
Now what we're going to do is we're going to play an audio clip from CBC's The Current, where we're going to actually hear the voice of a father after he had been to the emergency room. If we can play that clip.
The months passed. Christmas came and went. Mother's Day, Father's Day. And every time George Pearson visited Greg at the hospital, he had a mission in mind.
It was important for me to continue to make sure that people realized that Greg was not just a number or a dollar value, that he was my son and his name was Gregory Pearson and my name was George Pearson, and that every day everybody knew who I was and who Gregory was, and that they didn't forget that he's a human, that he's my child, that he's loved by his family, and that he deserves a certain quality of life like everybody else. And as hard as they were pushing to have Greg relocated out of the hospital and reminding us about the amount of money that it costs and the resources that it took up, we just had to keep pushing back and let everybody know that he is somebody.
Lessons learned there, a lot of pushback.
Yeah, I mean, I think that if you listen to that whole clip and their story, you understand sort of what can happen over time to a family and to an individual when the services they need aren't there. Yeah. And the importance of parents really speaking out about the humanity, that needs to be there and understood for their children.
Good thing to a lot of the parents, a lot of our audience's parents. So a good thing is that we're going to talk about how to help your voice be loud and not be loud, but help with the informing of the healthcare professional. This is one that I found fascinating. I wanted to make sure we talked about it. So the quote is, "When I got handcuffed by the police, It scared the heck out of me, as it would about anyone. And then same story. I had to wait, I guess, in the emergency room. I had to wait a long time. Then I was with all these people with mental problems. Like one guy was kicking the door, and a lot of people were making noises. It wasn't a good experience.
Yeah, I mean, I think in this quote, so this is a quote from a young man on the spectrum who had a really stressful experience that just kind of escalated and got out of control. And the police did come to his apartment, and he was handcuffed, and he was taken to the emergency department. And it really captures sort of just the sensory experience of how stressful that was for him, you know, and without any supports and nobody there with him going to the hospital, what that experience of waiting in handcuffs was like for him.
Yeah. Okay, so what we're going to do now is we're going to pause and we're going to take some of your questions, or at least a question from you. A reminder that we are going to do this from time to time throughout the broadcast, and so just submit your questions at any time through the Ask a Question box, and they will come right here to my iPad. The first question I have is, my child is only 10 and we have never had an emergency visit. All of the talk scares me. Do I need to worry about this?
Yeah. You know, I'd like to say absolutely, like, don't worry about it. But the truth is, there's a likelihood that in your son's lifetime there's going to be an emerge visit, right? Yeah. So we'll talk a lot today, I think, about how you can prepare if that kind of thing happens. It's not that these things are happening constantly all the time, but better to be prepared, right, than to just have this surprise where you thought it could never happen to you, because it can. Yeah.
So a very thematic question going into what we're going to do next is, let's talk about one of the big things, one of the big stats that you refer to over and over again in this talk is that came out of the study.
Right. So when I talked about the different types of studies that we've done in this area, one of the studies was working with this large administrative data set. Yeah. So we looked at a lot of people across the province, adults with developmental disabilities, including autism, and we compared their likelihood of going to the emergency department to people who do not have developmental disabilities.
Right.
So the stat is that in a 2-year period, 1 in 2 adults with developmental disabilities went to the emerge at least once.
Wow.
And what goes with that is that there was a subgroup of people who actually went repeatedly.
Yeah.
So the rates and the likelihood as well as the rate of going is much higher for people on the autism spectrum or with other developmental disabilities than what we see in people who don't have those disabilities. So we need to really think about this. It's a big issue.
Yeah. So maybe not something to be afraid of, as you said, but something to certainly get prepared for. So we get inside the numbers just a little bit here, and we talk about the actual frequency.
Yeah, so these numbers are referring to that study I mentioned about those families that we followed from Ontario who have teens or adults with autism.
400 families?
Yeah, so just under 400 families are giving us information every 2 months on the health services that they're using. And we found that in just a 2-month period, 1 in 7 of those families had some kind of emergency with their son or daughter. Often resulting in an emergency department visit or calling the police, something like that. When we follow them over time, at 8 months, that number went to 1 to 4. My guess is our study's ending now, and it's 12 months, that it's probably going to be more like 1 to 3.
Yeah.
And if we were to follow those families up to that 2-year period, it would be, the 1 and 2, or maybe even more frequent.
Wow. So, in having those discussions with those families, out of your study, what was determined to be the risk factors for emergency room visits?
Yeah, so using the information that we got from the families sort of at the point we call the baseline, where we started getting to know those families and their situations, we said, what are the predictors? What tells us why somebody goes to the emergency department and somebody else doesn't? The biggest predictor, the first bullet up there, says having an emergency visit in the last year. So if you've already had an emergency, you are way likelier to have another one, right?
Yeah.
Which I think speaks to the severity of the situation and also sometimes our capacity to respond to a situation and kind of resolve it or address it before we have another emergency.
Right.
But there are other issues. I think people who had problems with physical aggression to other people, they were more at risk of having an emergency health visit.
Okay.
And also people who were not doing anything during the day. So if you think about someone who maybe can no longer go to school because they're having issues at school or they're aggressive, or they've graduated from school and they have no program that they can attend regularly, those individuals not doing anything meaningful during the day were more likely to have these emergencies. And then the last predictor had to do with the family state. So we think of an emergency as being about the patient who goes to the emergency department. But it also speaks to what's going on in that family. One family who's sort of managing okay and feeling all right and not that distressed. These things happen. They know who to go to. They know how to get what they need. But the family where these things are really, really building up and they're starting to feel like they're in crisis themselves, maybe a situation that isn't a huge situation becomes huge for them, and it turns into an emergency.
Okay. Well, when we start talking about going to the emergency room with children on the spectrum, there's just two reasons they could be going, right? Medical or behavioral, I believe.
Yeah.
Let's talk a little bit about, how that impacts the experience.
Yeah, well, we know that people who are on the autism spectrum have a lot of different medical issues that can come up for them that they're more likely to have than people who don't have, autism spectrum disorders. So we might think about, for example, seizures being more likely, or gastrointestinal difficulties. Also, these individuals are more likely to take medications for a number of different things. Right? So sometimes we talk about sort of having some kind of medical, could be an injury, which is actually very common. And the injury isn't so much related to the autism. It's an injury that happened because of a whole bunch of other factors, right? So injuries, sort of, unwell kinds of symptoms, behavior that just isn't quite normal, but it's about a physical kind of pain. Sometimes it could also be something small that becomes very big. So an example in the study was someone who had a bee sting, an allergic reaction. But for that person, that was absolutely a terrifying emergency that turned into a whole number of issues once they got to the hospital. Or it could be a dental issue, right? Or it could be related to medications, the side effects of the medications making the person really, really constipated and very, very distressed and in pain.
Behavioral?
Okay, so the truth is there are a lot of other emergencies where there isn't an obvious medical cause. It's not an injury, it's not an acute, physical illness kind of thing. It's what we're seeing. And so it could be, like I said, aggression to other people, could be self-injury where someone's really hurting themselves, could be like that young man who was talking about feeling suicidal. So something that's more emotional or psychological that we're just watching in what they're doing or what they're saying as opposed to a clear medical cause.
And I imagine a big problem is when we're talking about the intermingling of both medical and behavioral.
Absolutely.
And the problems that arise there.
I think when we start to look more closely at the kinds of emergencies that these families are reporting, it's not really so clear if it's medical or if it's behavioral. It's almost like a dichotomy we use to make things simple. But so often they're combined. So with the bee sting example, what happened to that individual is he was so agitated. To everyone in the hospital, it looked like a real behavioral emergency, right? And it could be the opposite. It could be someone who is so upset and not able to cope with what happens that they end up injuring themselves, not on purpose, but through their agitation because they threw something, and then they cut themselves and they're bleeding very badly. So it's a medical emergency. But it's about that underlying emotional issue that made them hurt themselves, right? So very often these things are kind of intertwined, and it's hard to separate them out.
So we've talked about what gets us there. But once we're there, one of two things can happen. We can go and be not pushed out, but be sent on our way, or we can stay. So, did you find out what the predictors are for hospitalization versus going
so
home?
in one of the projects, the one where we actually went and reviewed hospital charts to find out what happened during the visit, we tried to see if we could predict why some people get admitted to hospital and some people at their visit get sent home. And it's a very simple slide because the truth is we don't know the predictors. We would think that the people with the more severe issues are the ones who get admitted, but that's not what we found. It could be about the time of day. It could be about the physician who's making those decisions. It could be about everyone else who's in the hospital and whether there's space or not. There's so many factors that come into play. We could not find, those one or two things that were really determining why some people get admitted and some people don't.
So you just mentioned a few of the reasons why we can't. But you would think that there's got to be a clear-cut answer to this, right? Like if I have a bleeding ulcer, I need to stay versus if I just have some sort of a stomach pain. Can you get a little deeper into the hospital and discuss some of the reasons why maybe people are not?
Yeah, again, if you go to the hospital and you say, tell us what happened, they won't even necessarily remember the case. So we can't always get that from speaking with
Makes
the people,
sense,
but what we did is we looked at the charts. We thought, at least if we can see what people were documenting at the time that they had the visit, what did they write down, the physicians or the nurses, that can give us some answers. So we learned a lot of really interesting things looking at the charts. One thing we learned is that the person has autism. The person has Fragile X syndrome, really important issues that are important in terms of how that person presents, things we should be thinking about. It's not always written down in the chart.
Wow.
So it could mean that the clinical team doesn't know about it, or they knew about it but they didn't think it was important, or they were concerned about what would happen if they put it on the chart.
Wouldn't it always be important?
I think it's always important, but
Right.
I think in terms of what they think, they may not realize the importance. I mean, if I feel like I'm dealing with it right now, I know what to do, why do I need to record it? Well, you also need to record it because they're going to come back.
Right.
And if they're going to come back, the next person should know that information, right? Or if they have a particular syndrome, there's a whole bunch of guidelines we have for that particular syndrome that would be really important for us to look up. And with a click on the computer, we could find what those issues are. So it does need to get recorded. The other thing we noticed is that often the clinicians didn't make notes about actually speaking with the caregivers to get information about the patient. And that's so important. You know, absolutely want to hear from the patient's perspective, but to get that full picture, you know, family's there and they have that history, we want that information to be captured and we want it to be in the chart.
Right.
We found that not everyone, even if it was more of a psychiatric emergency, they weren't always seen by the psychiatric or mental health team. And that's concerning. And so sometimes we think, well, when we want to fix the situation, we just need to go talk to all the psychiatrists and tell them what to do.
Right.
That's well and good if you know everyone's going to see a psychiatrist.
Yeah.
But if they're going to be stopped at that stage in the emergency care process where they just are seen by the emergency physicians, they have even less awareness of this population than they do in psychiatry. So we need to sort of work with both of those groups.
Right.
And then the last point says that when we looked at how people felt about the emergency visit and if they were happy with what happened from the parent or caregiver perspective, they were less happy when it was a psychiatric emergency as opposed to when it was more of a physical or medical health one.
Is that a commentary on what parents expect or the type of care that they get in the ER?
It's probably a combination of both, right? I mean, you want to go to the hospital so that they know what the problem is, they know the solution, and things get fixed.
Right.
But the truth is, not always easy to fix, and I think especially when it's more of a behavioral presentation, it's not something they can fix in that 3-hour visit.
Yeah.
You know, it's going to take a lot more peeling of that onion to find out what's going on.
Right.
And that's hard.
Holding true to our commitment to you, we're going to pause for a few more questions. This is an interesting one. A parent writes, I think our hospital treats us worse because of autism, so I thought a better approach would be not to mention it. I think we've talked about this, and I don't think that you would agree with that statement.
Yeah, I mean, I think it is true, and we've heard this, that sometimes people feel kind of stigmatized.
Right.
If people understand what's going on with their child, they're not going to give them the right kind of care. You know, someone with autism comes in here, oh my gosh, we're never going to be able to get them out. You know, so parents think, well, maybe if I just don't mention it, then I'll get the better treatment. I think what we need to be doing is educating the hospital about how to give better treatment to people with autism as opposed to hiding really important information about us. You know, it might work with that one visit.
Yeah.
It won't work for the whole person's life of their healthcare visits because they are going to have other visits, right?
Yeah.
So,
and as you were mentioning earlier, a simple medical condition of suturing a cut, you know, maybe it'll work, but for the more complex items, it likely will not. How can I support my adolescent son with ASD multi-diagnosis? Our local hospital is not able to support his emergency needs. Bit of a vague question.
yeah, I mean, the truth is I think having these complexities, these multiple diagnoses, all that kind of thing, that is just part of what we hear all the time, right? I guess there's a difference between how can I work with my hospital and how can I work with this emergency, right? And so I think we'll talk about this a bit more later as well, but, you know, that emergency, there's some things you can do, and you can't get a perfect response.
Right.
But thinking that the person might come back and we can do some planning to make things work better, you know, I think hospitals, they do want to collaborate, but they need the tools to know how to do it, right? They don't want it all thrust on them, like, you have to do everything, you have to know how to fix it. It's more like, well, I can do this piece, but who's going to work with me with the other pieces?
Right.
Or I don't want to help because actually I don't know what I'm doing.
Yeah.
So maybe part of this is education so they get more comfortable.
And a watch out for people on the line who are submitting these questions now is that we're going to get into some tools that are specifically useful for you when you're going into the emergency room, as well as talk about some of the work that you're doing with the hospitals and some of the things you're trying to get implemented. Last question, then we'll move on with the presentation. But what are my adult child's rights when the admitting staff will not allow me to be present during my son's evaluation? Because he sometimes has difficulties expressing himself.
Yeah, and that's something we hear a lot. You know, I think people think, well, if I'm talking to the patient, I need to talk to the patient. Well,
Right.
This patient, you know, has difficulties expressing themselves verbally, or if this patient gets so unbelievably anxious because his parent isn't there with him, then it's in his best interest to say, this is what I would like. And so I think it's his right to explain. But again, it's education. I don't think that the healthcare provider is trying to be mean. They don't know any better. They don't know why it's important to have the caregiver there.
Right.
So it's how you educate them and inform them about why this is important for this individual.
Okay, so We're going to move on with the presentation now, and the stat that we have up there is a stat we're going to continue going back to. If 1 in 2 people with developmental disabilities is going to the ER at least once in 2 years, we've got to be ready for it, right?
Yeah.
And there's a problem on our hands that we need to fix. So we're going to start talking about tools now, which I think is stuff that everyone sort of comes here for. Up on the screen now is the tools for primary care of people with developmental disabilities. What is this, and what help can it be?
So this is a really exciting initiative that was led out of Surrey Place Centre in Toronto. First in 2006, a group of people from across the country developed consensus guidelines for primary care of people with developmental disabilities, including autism. And then those guidelines were updated again in 2011. So they were published in the Canadian Family Physician, which is the journal that every Canadian family physician gets. When it showed up in their mailbox, it showed up with this orange book. And that orange book is a whole series of different clinical tools to actually help the clinician do what's written in the guidelines in terms of primary care. And primary care is really important for this population because so many of those emergencies we talked about, whether they're obviously medical or they're behavioral, but really it's due to that medical issue like the constipation, those things we're going to address by having good, regular primary care. And if I could tell people to do only one thing, it is to make sure that everybody has a full comprehensive health assessment every year that looks at the whole picture. I think especially, the mom who talked about her childhood, so many different things going on.
Yeah.
We're very busy dealing with each one of those things. We see lots of different specialists and we deal with lots of different issues. But when are we looking at things before they develop into big problems? We have to do good, solid primary care to be watching someone's overall health, and stay on it proactively to prevent things becoming emergencies.
One thing you found is a lot of medications taken by children on the spectrum. What can you talk to us about dealing with medications in there and when going into the emergency room?
Yeah, I think we probably could. It is a given that a lot of people on the spectrum take different types of medications, and all those medications have side effects. Right? Now, hopefully the medication is treating something and that outweighs the side effects of the medication. But if we're not monitoring those things well, we can have problems that lead to emergencies. So there could be a fall because of dizziness. There could be constipation that leads to absolute, impacted bowel, lots of very serious pain. There could be medications that don't go well together or an unusual side effect that doesn't usually happen in most people, but happens to this one individual. So monitoring medications is really important. If you have an emergency and you go to the hospital, making sure everybody knows about the medications as well as the medication history, right? So sometimes what happens is the hospital might say, well, let's just switch the medication. That's the issue. Well, you need to know the history before you just go tampering and switching medications. Yeah. And it may be that the primary care person or some of the specialists are the ones that understand the medications the best.
Well, I think that's common. I've been at the hospital with my grandmother, and they say, oh, it might be this medication. We should try this. To get to that medication, if the caregiver believes that they've taken the right steps and this is the right medication, what do you do when the ER physician is saying, let's make a change?
Yeah. Sometimes the change is a very good idea. I'm not saying that the changes aren't good ideas, but if you know how difficult it is to get to a group of stable medications that make sense, and you're working with a good healthcare team outside of the hospital, then maybe you want to have the input of that team in terms of making this decision. So sometimes it's just saying, could you please contact or check in with so-and-so who has been doing the medication monitoring to get their input? Could we maybe see about changing the medication, but first maybe I need to have that follow-up visit, or maybe we can have some dialogue. So don't just assume that that one medication is going to be the sort of the panacea, the solution, and switching it. We don't know. It's all trial and error. Right? So to be careful, I think, around our medication decisions and making sure that we're bringing people together who know your child best, right, about what's going to make sense.
Another item that you bring up here is life events. You got a very interesting slide here. Talk about that a bit.
Yeah, it's sort of the tip of the iceberg, right?
Yeah.
So I think when someone comes into the emergency department, we're focusing on the emergency. We're not thinking about life events. But we know that for this population, life events matter.
Right.
Sometimes they may be really obvious life events, like someone was traumatized, they were injured, they were abused, something really awful happened, and that has a lot of sequelae or things that can happen because of it, right? But sometimes it can be very small. So it could be, the bus that picks you up in the morning, the schedule has been changed, you're a different driver, You're coming 10 minutes earlier, so it's really changing that whole morning routine.
Right.
And the kid you usually sit with on the bus, it's no longer the same kid, it's someone else, and they're really, really, really annoying.
Yeah.
Or cruel or whatever, right? So that's a little change. A life event, not quite, but it can be tremendously stressful.
Right.
It might be that someone is very sick in the family. And, for example, one thing we hear about a lot is if a parent is very ill or if somebody dies, how that person with autism understands that situation and how that impacts them. So they may not realize that this illness can't happen to them, or that if someone died, that someone else they love wouldn't die, right? Or that that it's something they're even able to talk about or communicate. So many things can happen with life events. And I guess the other really important point about life events in this group is sometimes we think generally, well, if this sort of bad thing happens, it should affect you for about 2 months and then things get better. Well, with this group, it might actually have a much longer lasting effect. So they might ask in the hospital, has anything happened that really would have triggered this? And you're thinking, well, nothing happened in the last week that I can think of. But the fact that, his aunt died 6 months ago and he was there and he's still playing that tape of that death in his head all the time, that might be something that's contributing, right? So life events can contribute even if they happened a while back.
Your study dealt with adolescents and young adults primarily, and some of which are, fairly independent. Mm-hmm. Talk to us about, the unsupported, if you will, those who are out there. The first quote, the girl who walked into the hospital, on her own.
Yeah, I think emergencies are stressful for everybody on the spectrum. But a lot of our attention tends to go to those people who have real difficulties communicating their issues, who have need a lot of support day to day. The people who don't need as many supports, I think, sometimes get a little bit the short end of the stick, right? So they're doing okay when things are going well, but when things aren't going well, things really can fall apart very quickly. And sometimes at the hospital, we heard with this one young woman, well, why do you keep coming here? Well, if I need help and you can't give me the help I need here, please tell me where I'm supposed to get that help.
Right.
And if we don't have those alternatives available for her, this is what she's going to do, right? So when you think about other ways we can support people who don't have a whole lot of supports to prevent emergencies.
Okay. And you brushed over this earlier, talking about what can happen if people don't have activity in their life. But you talk about it again, the importance of meaningful daytime activities. And
I think this really becomes an issue for people when they do finish school, how important it is for them that they have something that they do that they feel good about day to day. And I don't think the answer is simply slot them into an activity, because if it's an activity that's stressful or that they hate, that might not be the best thing to do, right? But we know the people who have no activities that give them meaning and give them somewhere to go and give them people to interact with, those people are at risk for having crises.
Okay. A quote. We are learning each time the first visit to the hospital might be an emergency, but repeated visits represent our failure as a system to plan and put what is needed in place.
Yeah, so we talked about the fact that people have these emergencies. The first time, let's call it an emergency, but now we've got to start doing something about it. Right? So I think the flip side of what we've talked about so far are ways to prevent emergencies. Yeah. Emergencies happen, so let's make the interaction actually go a little smoother.
Right. Again, back to our quote, 1 in 2 people. Right. Got a couple more questions that I'm going to go to now before we move on to being prepared for the emergency. An interesting question. I'm not sure if you would have the answer to this, but how much training does emergency department staff receive before handling the patient or directing where they will be best treated?
Yeah, so training specifically in terms of supporting patients with autism spectrum disorders, they probably don't get very much training in that at all, frankly. Okay. This small group of individuals, let's say it's 1 in 88, they may have a lot of emergencies, but there's 87 other people who are not on the spectrum who also have emergencies. So I think, we want to advocate and we want to make easily available training there for them. But the truth is right now they probably don't have a whole lot of that training.
And this is part of the work that you guys are doing as well.
Exactly.
Right?
We're trying to think about ways to embed the training so that they can actually get it quickly and it makes sense. We can throw books and, I can give people a 2-hour training video. I can say everyone sign up for this day-long course, but there's so many competing priorities. Right. You have to think about what's the training that they need. It's about being comfortable with the population. It's about not knowing things and recognizing you don't know it, but this is where you go to get that information.
Yeah.
Right? It's about working with the families because they know things so well, how you can get the information from them. And it's about recognizing what you can do now in the emergency and what other people need to do in partnership with you after.
Okay. Next question is, family health teams have changed their practice to offer complete yearly physicals. This has now changed to once every 3 years. How can we ensure those with developmental disabilities are receiving regular care? Any advice, suggestions?
Right, so this is someone who really knows their stuff on the what we call sometimes the periodic health exam. It used to be that the family health teams could give everybody a regular physical, and now we're saying that the way you work generally with the population would be a bit different than that. But there are other guidelines, again, that orange book we put up before, there are other guidelines specifically for people with developmental disabilities, and they're not the same. So we have evidence from around the world that shows us that for this population, they actually need those physicals more often. And so I guess it's a combination of education with the family health team, knowing how they can bill for it. What do we call the exam if we don't call it the periodic health exam? And also working with people in policy to make sure that there's a way people can have those kinds of exams regularly. They're crucial. So it's a big part of what we're working on in our bigger program, which we call H-Card, sort of advocating for health in the population.
Not to put you on the spot here, but real life situation, this person here, should they point the physician, the what was it called, the family health team to that document? Is that
they absolutely? I mean, one thing might be to have a conversation with the family health team around, there are some really great resources that have been developed for this population, and I know there are some guidelines that have been written for this population. Would it be helpful if we shared some of that information with you? Because we know of a team of people who have been doing a lot of this work, and we have some of that info. How can we get that to you?
Right, to help promote what's right. Okay, so again, back to 1 or 2 people with developmental disabilities are going to the ER at least once in 2 years. Let's start talking about how to get prepared for it. A big part of your work, and a big part of even as you're working on getting the emergency room practitioners trained and all of that, there's stuff that we can do, stuff that parents can do and people can do when they go in. So let's talk about information for the hospital and some of the documents and stuff you brought with us today.
So one of the biggest barriers that we hear about from all the different perspectives is that they're not using the right information when they make their decisions in the emergency department. So I think it's part of our job as families to get that information to them, right, in a way that they can digest. So it doesn't work to walk in, like with every single assessment that's ever been written in a binder. I mean, you can have that, but don't be surprised if they don't want to look at that, right? Because they need quick information, and there's specific things that they're looking for. So there are different kinds of tools that have been developed. Sometimes they're called health passports. Are the one that we're working on for emergency departments we call the About Me little booklet, but it's just a very simple way of giving information about the key issues they need to know about for some of their decision making. So I can show, like, examples. This is the example of the About Me that we developed with Sunnybrook Hospital.
So it's being used at Sunnybrook right now?
So it's something that we're using through what we call our DD Cares initiative that we've started at Sunnybrook. And so it's information that captures right on the front page really important critical information about that person, including things like medications and allergies, contact information, as well as the key physician who's working with them outside. But then in addition, there's information in here from that person's perspective, because we really want the communication to happen with the person with autism and not just with the caregiver, right? So why am I here? What's wrong? How can the hospital help? But here's some things you need to know about me, about how afraid I am of this particular procedure in the hospital, about things you should say, things you should do, and things you should really avoid with me if you want to give me good care. Right. So it's putting that information up front, because it's going to change how that visit goes.
You mentioned up front, but just knowing the way the healthcare system works, where does this happen? Do we hold on to it? Do we actually see the doctor? Does it go in at triage? What do you suggest?
I mean, my suggestion is have it go in there as many places as you can. Okay. So this is this other example, which is up on the slide as well, which talks about sick kids. Yeah. It's something you would do electronically, and then it just spits out this tiny little laminated card that you stick in your wallet. Have a little bit of information, give it to the first person you speak to, give it again to the next person that you speak to. Realize that just because the first person you spoke to got that information, it doesn't, telepathically get communicated to the next person. Right. You can have a few copies. The important thing is that it's updated. You don't want to walk in there with a document that you worked on that was perfect, that's 4 years old, and has the wrong medication information.
So the DD Care stuff you can find in the resource section on the H-Card website, or link out to it. And then this last one here is on the Sunnybrook website.
This one is on the Sick Kids website, so it's called the Good to Go program, which is about transitions.
Fill it all in, keep it in your wallet.
I mean, the bottom line, I think, is get something that you think expresses what's going on in your family. Get it going, and there's several different versions. But the important thing is you have some information when you walk in there to help them do their job.
Now we're going to talk about extensive crisis plans.
Right. So you can have that sort of one pager of a little bit of information,
Right.
but you also need to know, in this situation, do this. When it starts to escalate and it gets a bit more severe, that would be a good time, for example, to take the PRN medication or to let the police know things are kind of escalating. When it gets to this point, this is a really good time to go to the emergency department and to have some shared decision-making around kind of what that staged process looks like. So people are in agreement about when it is the right time to use the hospital. One really important thing about developing those kinds of crisis plans, you want the clinical people who know that person best involved.
I would say, yeah.
But you also want the hospital involved. So sometimes what happens is people make these great crisis plans in the community and they never actually get it to the hospital. The person ends up going by themselves. The hospital has no knowledge of the plan.
Right.
Right? Or the other thing that can happen is a plan gets developed. People walk into the hospital. Here's my plan. Do what's written on it.
Yeah.
But the hospital never saw it.
So
They weren't part of the process, right? So it's not feasible. It doesn't make sense to them. It feels like something's being thrust on them. If you're trying to work collaboratively with the hospital, you want them involved in terms of doing that crisis planning.
So let's just say, so you're saying that they ought to be involved in that. Let's say they weren't and you've got a crisis plan. How do you share with the hospital? Do you walk into Emerge one day and just say, hi, I might be coming in soon, here it is? Or is there an actual mechanism by which to do this?
I think every hospital is different.
Okay.
But to be honest, calling up the Emerge and walking in one day isn't a bad idea.
Okay.
If your child has already been to the hospital and you've had an experience that wasn't great, how can we do planning for next time? Who's the person we should talk to? It might be someone in the social work department. It might be one of the lead nurses who work in the Emerge. It might be someone from psychiatry, but there's someone in that hospital who can help you with what we call care planning.
Right.
And the best time to have the conversation is when it is not an emergency.
Right.
Right? I mean, not only can you bring in your different pieces of paper in that emergency, you can also have things that are electronically stored in that hospital's information system. Because that's the first thing they do in the hospital, right? They type in your name,
Yep.
stuff pops up. So you want to get that plan right into the hospital.
Okay. So we're hearing a lot of this stuff needs to be done before, as you mentioned. What are some other things that parents could do to be prepared for? Because it's inevitable. In most cases we have.
Yeah,
severe-
it might happen. So what kinds of things can we do to prepare?
Exactly.
So I think back to when I, was reading pregnancy books, and thinking about the things we have to prepare in case, for when we go to the hospital.
Yeah.
These guys are going to go to the hospital at some point. So have the backpack ready
Right.
and think about the things that need to go in there. Right? So it might be, first of all, and it's not a joke, food.
Right.
Right? If there are like favorite snacks or favorite drinks and you're going to a hospital where the cafeteria is closed and none of that stuff is available and you have to wait for 12 hours to be seen, have the food with you that you like. Have your medications because they don't distribute or they don't give you your medications because you forgot them at home.
Right.
So have those timed medications that are really important with you. Have activities to do because you're waiting for a long time so you don't get bored.
Right.
And so that the person you're supporting with autism, that they're, as calm as they can possibly be. Have information that you can show that illustrates either how big the problem is or what things are like when there isn't a problem. So, for example, if you're bringing Amy in because she just trashed the house, Amy might be very quiet and sedated by the time she's seen, but you want them to understand how trashed the house got.
Right.
So take a picture with your phone before you come in, right? And show that.
Yeah.
Or if you want to explain what Amy's usually like when she's not this agitated, show a quick clip on your phone or a quick little video or some pictures of what Amy's like in her work setting before she started to have those difficulties or how she takes care of her house. She could use that also to talk to the healthcare staff about things. It's also an engagement strategy,
Right.
but it helps the staff know how that person is different from their baseline.
One of the biggest indicators for future emergency room visits or department visits is if someone's been there before.
Right.
So do you have any tools that help learn from a trip to the ER?
Yeah, I mean, I think one sort of misnomer, people kind of think sometimes if I've been to the emergency department and they give me my feedback of what I'm supposed to do, somehow everybody then knows what happens and things get put into place. But the truth is, the emergency department's done when they say goodbye, right? So it's not their job to be communicating and reaching out and talking with your healthcare providers. So it's your job to make sure you understand what took place in that visit and planning for some of that follow-up. So when I think about follow-up, I think about debriefing, looking at what happened in that situation, what worked, what didn't, what do we have to do to plan for next time. If we need to do more crisis planning, if we need to get in touch with the hospital, doing that work and doing it as a group, right? So it's including for sure the primary care doctor who's involved with the ongoing, sort of medical care, as well as any specialists who are involved with you, or you might be working with a behavior therapist or a teacher or somebody with some really good ideas. Get everybody together and do some of that planning. I think one thing that can help, and so one thing we're working on again through our DV Cares initiative, is looking at how we communicate the information about the visit. Sometimes there's like a standard letter that gets written to the doctor, and it's a little bit of a scribble or it's a typed thing, a lot of medical terms. You don't really understand that. So you want to make sure you understand what that clinical team thinks happened, so you know what you're supposed to do at follow-up. So we talk about doing a today's visit exit interview, where you're really highlighting this is what happened at the visit. And it's called an interview because it's a dialogue. It's the healthcare provider explaining to you what they think happened, and you understanding what happened, and you knowing what the follow-up needs to be. So this is a form that we would want people to get filled out so they know, was a new medication prescribed? When am I supposed to take it? When do I come back? What would be problems I would be looking for? Are there any other people I need to see after this? Am I going to be following up with a social worker to do some planning? Is there a psychiatrist I need to be visiting? So what are the, do I need to get the sutures off at a certain time? So that information is in here, as well as the procedures. Because if they just say, well, what happened? Well, I don't know. We talked to someone. Well, who did you talk to? What do they recommend? I don't know. So it's a way of having that conversation so you really understand what has happened and what still needs to happen.
For those not lucky enough to have that implemented in the hospital near them, they can go to the HCARD website, they can access it. How do you suggest they go about ensuring they have this information at the end of the hospital stay?
Yeah, I mean, even, who's really going to remember to show up with this little piece of paper? If the hospital doesn't already have it, you probably won't have it yourself, but you can remember to say, you know what, can you put down in writing for me what we did today? Because I just need to understand, because I know it's my job to go back and talk to the doctor about it. I want to make sure they understand what we did and what you suggested, because I actually don't get what you're saying. So can we write this down and make sure I get it? Listen to me say it and make sure that I'm saying what you think you said to me. Have that conversation. And don't rely on anybody to do that communicating for you.
Right. Well, if they print it and put it in their bag,
they might have it, and they could show it if they did that. And the team might be really responsive and really appreciate that, or they might kind of look at that and say, that's not part of what I usually do, right? So then it's that kind of education and collaboration around how we can try to make things simple. We're not trying to make their job more difficult, and I think that's important to run. We're not trying to give you more work, but we're trying to make this visit really help us so that we don't have to come back next time unless we have to.
Yeah,
right.
Making the work that they did for those 4, 6, 12
worthwhile.
hours,
Absolutely, you spent 12 hours with us. Let's make it worthwhile.
Right. What else are you doing to help people prepare?
There's different things. I have an example here. We've developed a kind of social story that you can use. So if somebody is actually in the emergency department and they're sitting for a long time, wouldn't it be nice to be able to go through a social story that outlines the different things that might happen at that visit? So the different people that you might see, the fact that someone's going to give you an identification bracelet, that they have to take your bag and put that away, that they're going to call your name, that you have to wait a long time, that it might be noisy. So I think having something like that can be a good tool. Having videos that you can watch that explain what happens, and also using videos as training tools where people with disabilities are teaching the healthcare providers how to do the right kind of care and the assessment. So we're working on those. And, on here on how to prepare, we also have the comment that, when things aren't that bad, I said it doesn't hurt to walk into the emergency and say, hey, we have a plan.
Yeah.
Go see the hospital, right? Again, if you're pregnant, you go and see the hospital where you're going to be giving birth, right? And you get the whole tour. Have a tour when you're not in crisis, especially if you've had a bad experience at the hospital. It's probably really important to have a good experience before you go back again for another emergency.
Yeah, exactly. So you're working with all sides, and can you talk a little bit about some of the stuff that you're doing with at the hospital level, some of the work that you're trying to do there? Yeah,
I mean, I think the truth is, I think, we're talking to families today, as families, you're interested in what you can do, okay? Unfortunately, in the emergency department, I think it's not that they're not interested. It's just that there are so many competing things they have to be interested in. Right. And like I said before, 1 in 88 is not as common as the other 87 people. Right. So we have to find a way to work with the hospital to fit what we're doing about this population into the practices and the things they're already doing. Because if we just say to them, please, everybody needs to take 25 hours of training, that's an expensive endeavor.
Right.
And the truth is, if you do the 25 hours of training, but you don't see your first patient for 3 months, you're going to forget everything you learned.
Oh, yeah.
Right? Because everyone's working on shifts, so not everybody's going to have this experience every day that they're working, so it's that much harder to remember it. So part of what we're doing with the hospital is we're thinking about things like, if you're going to pull out and offer to new patients an About Me form that gets completed, where does it go?
Yeah.
And what size should it be? Like, what fits well, And if we're going to have this binder of resources, or if we have here this exit package that we want the clinicians to give to the family before they leave the hospital with a lot of follow-up information, where do we put these folders? And how do we help the nurses to remember that they have to share these folders? So it's all of those kinds of questions. Even how to get people to come to a training. If we want to give them information and show them stuff, do we have prizes? Do we say it's required? We found that if you offer food, actually, in a really busy emergency department when you don't have time to go grab a meal, if there's a good meal available there, that's a good way to get people to come by and take a look at the resources. So.
A couple other things you had up here was essential information for emergency room department, ED.
Mm-hmm.
So
that's just an example, again, from that orange book I showed before of primary care tools. That's another example. Instead of using that, sort of about me information booklet that I showed, it's just a one-page piece of information with critical information that they're going to need at the emergency department when you show up.
Something that they should have.
Absolutely, and anyone can download that off of our website.
Right. Okay.
So, and then this other one is, again, from that same Primary Care's orange book, and it's downloadable on one of the websites we'll put under resources, but it's just some specific, if you're calling 911, for example, there's certain things you can say at that 911 call that will make that visit less stressful and more useful for the individual with ASD. And similarly, if you work with the police, sometimes you can get information right into their computers if you ever have to call them. So there's just some suggestions for things caregivers can do if there's an emergency.
We already had one person say that they haven't been to the emergency room yet. Most of us, I think, have in some way. But what can parents, caregivers, what can everyone expect from the emergency room?
Right. Well, the first point on here, and everyone kind of knows it, but we forget it when we're there, is that you'll have to wait. Even if you're on the autism spectrum, even if it's a really big emergency, you're still going to really have to wait because it is based on everybody else's emergencies that day. Right. It's not just based on your emergency. So things you can do to prepare given that you're going to have to wait a really long time. Knowing that it is not a smooth process where you give your information at the beginning and they read it. You might put your about me on the clipboard. Doesn't mean anyone opens it for sure, right? You might have to answer the same questions to several different people. And that's just part of how things go. You also really need to know that it's not their job to do all of the follow-up care necessarily. So that idea about doing the planning after and the debriefing and connecting all the dots is not what they're focused on. They're just focused on the emergency.
Mm-hmm. So almost everything I know about the emergency room I learned from TV, shows like ER and House. But what realistically can emergency room physicians and staff do for us? Like, what should we expect of them?
Yeah. I think one of the most important roles that the emergency department plays, obviously if it's a medical emergency, but even if it's behavioral, is it's their job to help figure out if there's a medical cause to the emergency presentation. Okay, so sometimes it's an emergency, it's the middle of the night, or you can't even do a nice physical exam with the person in the doctor's office because of how they're acting. An emergency department can help you deal with that issue and find out what some of the medical causes are. So that's something they absolutely can do. And they can also, it's a safer place for someone to be when they're at risk of hurting themselves or hurting other people than just being out there in the community, right?
And we hear often that emergency rooms maybe aren't used correctly. We hear often that it's a burden on the healthcare system. Obviously, they're there for a reason, but I think it's important for people to know what are some expectations of what they can't do or what they're incapable of doing.
Yeah, I think people think, well, if I go to the emergency department, they're going to be able to solve this really terrible problem that's been building for all this time and no one can figure it out. And the truth is they can be a safe place to try to rule out some medical concerns, but they're not the experts on their own, right? At getting that specialized kind of assessment and treatment. They're just the beginning point. So they may be able to lead you into that more, like if someone really needs to be admitted as an inpatient and then a lot of tests need to be done, great, absolutely. But if it's going to take a lot of work that has to happen outside of hospital, and it's really a lot of it's about the autism, the expertise is not in the emergency department.
Right.
No matter what, even if we know what kind of environments are going to be conducive or helpful for people on the spectrum, that is not something that is easy for the emergency department to provide. And also, they can't keep doing that sort of ongoing. Like some people really do use the emergency department because that's the place where everybody's there and everybody cares and you get a sandwich and they listen. That's not the best place to go for that.
Right.
So you might be able to work with them to try to make that connection to figure out where you can go for that, but you shouldn't expect that sort of ongoing kind of therapy from an emergency department. And then the last thing is, people, I remember I said it's the barometer, right? It's when everything is wrong in the system, you go to the emerge.
Yeah.
That doesn't mean that the emerge has the capacity to fix that system. So I think it's not fair to put that expectation on them.
Having problems with the system, where do you suggest people go? Like to help fix the system, what can they do?
Well, lots of opportunities all the time.
Yeah.
There's different places I think you can work. First of all, I would say if you want to fix the system and you find other people who are interested in fixing the system with you, that kind of collaborative, positive approach to things can be super effective sometimes. Yeah. So find people who already are making a difference and doing a good job and work together. I think the power of many voices is much better than several individual stories. So I think Autism Ontario is a great advocacy organization in terms of some of those issues. Sometimes you can speak to, people who are more politically involved. Sometimes you need to work with the media to get your story addressed. But again, I think focusing not just on the negative issues, but the positive ones is really important. And it's part of our larger program, the Healthcare Access Research and Developmental Disabilities Program, is really looking at how we can bring policymakers, families, healthcare providers together to improve the health of this group. So I think we're happy to hear kind of what's going on and see if there's a way we can also help together to make people healthier here in Ontario.
And that's important. We talked about it in the pre-interview. The HCARD website available in our resource section is a place where you can go see these resources and provide feedback, most importantly. Try them. I mean, this is an ongoing work that you're doing, always looking to improve and help improve the healthcare system. At this point in time, we are going to break for your questions. This is going to be our last opportunity as we near the end of our I believe it's almost been an hour. Reminder to submit your questions in the Ask a Question box, and they will come here to my iPad, where I will be able to ask them of Yona. So, waiting for these last round of questions to come in. Maybe what we can do while we do that. Nope, here they are. As professionals, how do we access the resources and tools to share with our families?
So if we're thinking about the resources and tools and things that we were discussing, we're trying to put all the resources in one place, or at least link them up all in one place. Right. So under the HCARD website, you'll find a specific section of tools and things that would be helpful for caregivers, for patients, and also for clinicians. Yeah. The primary care tools that I spoke about, we link to them through our website, but they also can be found if you just type in Surrey Place Centre primary care. You'll see all those links and all those downloadable forms.
And the eventual location for all these resources is the DD Cares.
Yeah, so DD Cares is what we call the program that's really trying to change our health care for people with developmental disabilities, and that's kind of part of the bigger HCARD program. Right. So you can go to ddcares.ca or hcard.ca to get that information, or just email us at ddcares@camh.ca, and we'll help you. We'll help you navigate. We're actually, I heard that in the office we're working hard to update the website right now. So it's constantly a work in progress. It's something that we're working on in the long term. So check it out, but check it out frequently.
Cool. How do you suggest families or caregivers ensure information is transferred between hospitals when a patient moves, especially if the parent or caregiver isn't there to advocate for the child?
Yeah. I mean, I think that's where your role as an advocate is, to try to help other people be advocates as well. In the perfect world, we're going to have these electronic health records that follow us wherever we go and that are accessible across places, but that's not the case right now. Yeah. But again, if you have that primary care provider, they're your medical home, right? So if they hold that information, they might be able to help transfer that information to the next primary care provider, and then maybe that is one way to get information out to other hospitals. The other thing is that usually when you go to a hospital, they're going to ask you if you've been to another hospital before, and you'll say, well, we did visit here, we did visit there, and then they can access that information right away. Even if it's in another city, they contact them, they get permission, they fax it, they look at it, right? So if you're not there as the parent, make sure there's some kind of passport or about me information card or sheet that individual has with that information on it, and work with the people who are supporting them, if it's not you, to make sure it stays updated.
Topic for another day, but love to know how the Gap knows everything that I've bought from store to store. We're still dealing
they
with that.
figured it out, but we can't figure it out in healthcare.
Exactly. Unfortunately, for the people online still submitting your questions, we have run out of time for the day. But I do want to give you the final word. If there's something that you want to ensure that our audience hears from you today, what might that be before we do go?
Well, I hope we didn't really scare everyone today. I know that was a bit of a theme, right? These things can happen, but I think there are also really amazing things that people come up with. Families, there's like that angel of a nurse or a doctor who does something amazing in the hospital, and I think we have to capitalize on that. We can learn as much from those things as we can from bad situations. And even when there are bad situations, we can learn from them to prevent the next bad situation. So to kind of encourage families to be talking with each other, sharing their stories, and sharing them with us at HCARD so we can learn from them and help everybody's healthcare get better.
Yeah, Great. Well, again, all the time that we have today, a reminder that an archive of this presentation will be available on the Autism Ontario website in the coming days. So if you know a friend, a family member, or even a healthcare professional you think might benefit from this broadcast, you can feel free to share it with them. A reminder that any questions, comments, or otherwise that were submitted but not responded to, Autism Ontario is going to work with Yona to get an FAQ up again in the coming days for everyone to review. On behalf of Yona, myself, and Autism Ontario, I'd like to thank you for your participation today, and we look forward to seeing you at the next Autism Ontario event.